and I heard that it was originally it was like an hour and a half.
Yeah, I have a lot of questions on that, but it depends on how much do we need to know.
Okay, so the parts that I told you afterwards in 3 minutes is what we kind of need to know, not the 67 minutes of what Rob actually did there. So basically, you're going to need to be able to identify right atrial enlargement, left atrial enlargement, left ventricular hypertrophy, right ventricular hypertrophy, and left and right axis. Those are the 6 things we really need to know.
And the best way to go through that is going to be by watching that lady's video.
Watch that lady's video, or we'll do tutoring. If you have time this weekend, book a tutoring day. And really, it's super simple. You're looking at lead 2 and AVF.
So I know that, I watched a lady and I saw her thumb thing, and that was really helpful. But I think maybe it's just because I haven't studied enough on my own. But for me, for the cardiac rhythms and the strips, knowing even which one is the lead 2 and which one is the lead 3, or how that works, is it?
Okay, so hang on one second. Let me show you here. All right.
By the way, it's lead 1 and AVF.
Lead 1 and AVF. You're right. Lead 2 is the one we look at for the P waves.
Yes.
Mm-hmm. Lead 1 and AVF. You're right, brother. Thank you for correcting me. I appreciate it. I do.
Hey, do you think we could go over the patient of the week stuff with the volume loop and?
Yeah, we're gonna go for that for sure today.
Okay.
Yeah, I heard, Rob, that a lot of your stories start out with, after about 3 beers, I just sat down and just, then complete the sentence, man.
That's usually how it goes.
Yeah, okay.
I'm serious, man.
No, I got you, man. I got you.
That's when my best creative writing comes out.
Yeah.
So is it just that lead 1? Is it just called lead 1? Or is it also
Hang on one second. Joe, I'm about to show you here in a second here. I'm just doing it off the screen so you didn't. Okay, here we go. So. Okay, can you see it? So that's what lead 1 is telling us, right? That's where lead 1 is covering. What's going on top? All right, lead 2 on the right side of the heart. Lead 3 on the left side of the heart. That's kind of like that's was that what you're looking for, or?
Yeah, and then on the strips, it just goes 1, 2, 3, 4. It just goes down on the strips. Is that how?
Well, no. What happens is, hang on, we'll go down. So usually the bottom one is all lead 2, right? This is just lead 2. This is just over the whole period of time. So it's 1, 2, 3, AVL, AVR, AVL, AVF, and then it's V1, V2, V3, V4, V5, V6.
So there should only be 4 of them.
So there's 6 actual leads that would 9 actual leads, and then 1 is the strip, is lead 2.
Mm-hmm. Okay. Yeah, I think I haven't taken enough time to study it, and I think that's probably just what I need to do.
Mm-hmm. But don't get too in depth, seriously. Unless it's really, something that you're very weak on as far as your TMCs and stuff like that. I wouldn't take away too much time on this. If you feel like it would be a time best served doing something else.
Well, see, I was thinking that. I was like, I don't really need to worry about this. But then I talked to Marissa, and she was stressing me out. And so now I'm like, gosh, I need to study this.
Yeah, Marissa seems like a super type A personality there.
See, Marissa?
Hey, guys. Hey.
Hey.
I mean, on my TMC and my exams, like I get them right, so I like.
Yeah, so I seriously like this is stuff that you know once you get out and you start practicing and stuff like that, you take all the time you want to whenever you see them to look through them. You know, I just really want you to be able to look and see if there's something that could be chronic, or pulmonary going on, chronic or acute, and
Okay.
and those are the basic things I'll tell you. So right atrial enlargement, left atrial enlargement, left and right axis, and then left and right ventricular hypertrophy.
Yeah, I was trying to get Marissa to teach me, but she wasn't having it. And I guess I should ask my husband since he works in the cardiac clinic. That would probably be helpful.
Okay. All right. Any other questions about the EKGs?
Is it just this week and then they'll be gone?
You'll probably see about 4 or 5 questions on the final, but not
Okay.
much. Not much. And like I said, and that also, that includes like the heart block. You got a pretty good grasp on the heart blocks?
She loves them.
You love the heart blocks?
Oh, I hate the heart.
You hate the heart.
Hate
Okay.
it. I hate it. I'm ready to let's move on. I
Okay.
don't like this
Alright.
topic.
Okay. All right. How about capnography? Everybody's good with capnography?
Yeah, capnography is pretty good.
Okay. Shunt and dead space?
Don't like shunt and dead space.
You said dump that?
I don't like
Oh, you
shunt.
don't like, okay. I mean, if you think,
Yeah, can we go over that too?
okay, so let's see here. So for the most part, right, when we talk about shunt and dead space, we're looking at the VQ ratio, right? Is that like basically what we're looking at here?
Uh-huh.
All right. So when dead space is what more than what? What is dead space?
In the homework, it was like I
mean, as far as like, more ventilation or more perfusion? Like, what is dead space in simplest terms?
Yeah.
more perfusion. I don't know.
Okay. Rob, what is dead space?
I wasn't gonna say either of those two. I was just gonna say that was the volume of air that wasn't.
We're participating in gas exchange, right?
Yeah.
Okay. But in terms of,
Yeah.
VQ, dead space versus shunt, it's, more ventilation than perfusion. Increased ventilation, less perfusion, right? Everybody get that? And shunt is the opposite, is increased perfusion with no ventilation or less ventilation.
I gotta have some visuals here.
All right, let's go. Hang on one second here. Okay, let's not this one. Okay. Let's see here. Okay, let's see what we get here. Okay, so here, so shunt perfusion greater than ventilation, right? And dead space is ventilation greater than perfusion. All right, so let's talk about COPD and why that's a dead space issue. All right, so do we know what kind of volumes on COPD patients, right? What kind of volumes, Rob? Usually. What do we see volume-wise? Large volumes, right? So increased, they breathe a lot. I mean, their lungs are very floppy. Their rate is usually high. So increased ventilation. Am I right? So probably if somebody normal minute ventilation is what 5 to 7 now they're teaching. So somebody with COPD is going to have to breathe in more all right, because they have some diffusion issues, right, in order to get enough oxygen in. So increased ventilation, all right. What else do we know about, you know, the COPD circulation? Usually have what type of issue? Matter of fact, you talked about it in your 40-minute EKG rant.
You're talking about diffusion.
Well, not just not well, yeah, diffusion, but what else?
Oh, creating pulmonary hypertension.
Pulmonary hypertension, right? So high pressure, so that decreases the amount of circulation that actually gets through the lungs, right? So we have less perfusion. So just mathematically, increased ventilation and decreased perfusion. I mean, that is a perfect dead space issue right there. And also, if you think about it as well, another one that we uh, include as dead space are pulmonary embolisms, right? We have a blood clot blocking the ability to perfuse the lungs, right? For the blood flow to get through the lungs, so that it can actually take part in gas exchange. All right, but we have the same ventilation, but we have decreased perfusion. So once again, dead space greater than perfusion, we have a dead space issue. Ventilation greater than perfusion, dead space issues.
So, do COPD patients have poor circulation always because of pulmonary hypertension, or is it?
Okay, say that one more time, Jill.
Do the COPD patients always have poor circulation due to the pulmonary hypertension? Is that the main reason for that?
Well, well, not only that, smoking, is a vasoconstrictor, right? So it's not just pulmonary hypertension, but a lot of times, you know, since we're respiratory therapists, that's what we're more concerned with, all right? How our ability to diffuse and perfuse. But they have a lot of issues because the thing that they do for 40 years or whatever, 40 pack years or whatever they have is a vasoconstrictor. All right. And so they usually have circulation issues. And that's why a lot of COPD patients have very cold hands. All right. How many times you try to get, a pulse ox on a COPD patient and you can't get one, right? Perfusion is bad. Because for 20 something or 40 something years, whatever they did, they voluntarily put a vasoconstrictor in their body, and now, circulation is suffering. Have you ever had that where you've tried to get you try to get a pulse ox on somebody and they have very cold hands, a COPD patient?
like Raynaud's? Yeah, with pulmonary rehab, we had a bunch of those.
So, you know, all of that leads to this. Like COPD patients have a lot of those type of characteristics, these circulation problems.
Got it. Thank you.
So, so tell me why, Sam. Tell me why pneumonia or ARDS is a shunt problem.
Because there's a blood is shunted away from those areas. Like the body will prevent blood from going to those places because it knows there's no gas exchange happening there.
Well, okay. So a couple things with that. So let's just look at it mechanically, right? Let's look at it, as far as a shunt versus dead space. All right. So not just like a left. We're not talking like a left to right shunt. What we're talking about is our VQ ratio going up or down. All right. So we're talking about you have what do we know about ARDS lungs, right? They're very stiff, non-compliant, right?
Yeah.
Very hard to get volume in, right? So decreased, they have a decreased capacity to ventilate, right? We have to try to ventilate them, and so usually we have to do a lot lower volumes than we need to. But usually, most common reason for ARDS is sepsis or all over body, all over body or multi-organ infections. And so now when that happens, we have a fever, so we have increased metabolism, so we have increased circulation and a decreased ability to ventilate and get enough air in to perfuse, to have gas exchange. And so the ability to ventilate is less, so less ventilation, and perfusion is usually a little higher. Cardiac output is probably a little higher. Then that would be a shunt problem.
Okay.
Any other questions on this? And during during the tutoring session, we can go, deeper if you want. Any other questions? Shutting dead space.
It makes sense when I think it's just associating because it gets kind of confusing, like with the wording wise. So
Yeah,
I
because we use shunt in a couple of different ways, like left to right, and but when looking at just mathematically, right? So is this person? So what are we going to do for this person? Do we have refractory hypoxemia, right? That's more of a shunt issue, all right? Dead space issue is more of we're talking about a gap, like the gradient between PACO and PECO. And when we talk about shunt, it's usually we're looking at the gradient between, excuse me, the A to A gradient. So if usually, now not all the time, but usually, if you ask yourself, is this A to A gradient problem or the P to F ratio problem, or is this a, PACO minus PECO problem? That would help, determine which is which. Did anybody record? I always forget to do. Oh no, somebody did record. Thank you. All right. All right. So let's talk about this. Let's see here. Let's go Microsoft Whiteboard. So let's talk about the patient of the week this week. All right. So let me give you a little sad story here. The guy was like 82 years old, Hispanic guy, field worker right up until recently. We don't know much of his history, but he didn't have an advanced directive, right? So he's got COVID, and he didn't understand what's about to happen to him, right? We didn't have a translator there, unfortunately. So we get to the point where it's okay. Now we have to intubate this guy, and he wakes up like as soon as he's intubated, and he's like, "No, I didn't want this. I didn't want this. No, no, no. Well, it's too late now. We got the tube in you. All right. So he's been on a vent for a while, and he's been breast stacking, right? So let's talk about breast stacking, all right? So we talked about it yesterday, right? We're doing something that looks something like this. And this is, and sometimes even 3. All right. We'll talk about repeatedly. We're looking at like the volume waveform. This is what we're looking at. All right. So now what's the problem here? Like this is a big problem. We can't allow this to happen, right? So Sim, tell me about this, man. What's dangerous about this?
Couldn't it just cause too much pressure in the lungs?
Too much pressure, right? Too much volume, right? We can get and that's what wound up happening. So in between, by the time I got there at one night and the next morning, or the morning after, or the 2 mornings after that, or somebody had spotted a small pneumo, right? So it was like, all right. So, but let's talk about how we can get the right settings for the gym. So let me ask you guys a question. So what do you know to do about breast stacking? And how much have you guys talked about breast stacking?
I can't remember us ever like in a class going over it. I think the only time that I really learned about it was in clinicals. Like they'd be like, "Oh, this is breast stacking," but I mean, you guys can tell me if I'm wrong, but I don't remember anybody ever telling us like, with breast stacking, do this to fix it.
Listen, breast stacking is a real problem, and it happens all the time. I'm surprised we don't talk about it more. All right. So, usually there's 3 ways to go about breast stacking, right? There's three possible ways to help with breast stacking. All right. So, anybody have any idea? So let's brainstorm this. Like, how would you deal with the breast stacking?
Could you switch him to like SIMV with a high pressure support?
Okay, so it could be, okay, hang on a second. Okay, that's a possibility. And what does that do?
Essentially, you can kind of decrease the mandatory rate, and so the patient's able to breathe in their own tidal volumes. And then with, you can increase pressure support to help them get more tidal volume if needed.
Okay, so that's one way, is giving them like SIMV. All right, what's the second way? Marissa, give me a second way to deal with breast stacking.
I'm not really familiar with it. Maybe adjusting like the I to E ratio.
So possibly, yeah. So some people think it's a flow hunger problem, right? So you can increase the flow. That's like the simple way to try. Okay, so that's a simple way to try. So some people say, okay, with breast stacking, that's he is, he's flow hungry. He wants some more flow or some more volume or something like that. All right, so that's a way to try it. What other ways? Sam, give me another way to deal with this.
Can we just put him in a pressure support / CPAP mode?
Okay, so totally spontaneous, right?
Yeah.
That depends on a couple things, all right? That depends on a couple things. So how sedated is this guy, right? All right, because we take all rate away from him and let him do all himself. If he's not, if he's not strong enough to do that, that's not going to work. He's going to flame out, increase heart rate. What else?
Sedate him and put him on a
Sedate?
control.
Sedate, yes. So usually, depending on the RT, this is the easy way for us to deal with this. All right, totally knock out his drive and let us ventilate him. Totally, right? So that's kind of the easy way to do it, right? You can just totally take away all his desire to breathe and just provide the rate, no more breath stacking, done deal. All right. Now, what's the problem with that? So this gentleman here, when I saw him on Sunday night, he had a heart rate of 51. All right. So what is that telling you?
If we sedate him more, we're gonna knock out.
Yeah, if we're gonna sedate him, if we sedate him anymore, he's gonna stop. His heart's gonna stop. Right? We can't afford to get that heart rate any lower than it already is. All right. So the first thing I tried was, okay, let's go in. Let's increase the volume. Maybe he wants a little more volume. All right. Increase the volume. Hung out, watched for like 5 minutes. Still breath stacking. All right. Now it's getting a little scarier because now him breath stacking like 450 or 430, whatever he was at, breaths, now he's stacking 500 milliliter breaths. All right. And peak pressures are just getting higher. All right. So we try, pressure, but we put him on pressure and we still got breath stacking, right? Not really doing anything for him. All right. So what we have to do is can't sedate. SIMV wasn't really working because he was still breath stacking. Even no matter how low you put the mandatory rate, when he came upon a mandatory breath, he would stack it. He was just fighting the vent with every fiber of his being. It's like he almost like, it's like he was trying to kill himself. All right. So last thing we tried to do is put him on a spontaneous CPAP mode. All right. But let's figure out a way to make the settings optimal. All right. Now, when we talk about optimal, one of the best ways to set up an optimal vent setting is using the volume pressure waveform. All right. So now this is, all right. So this is like 5, 10, 15, 20, 25. Okay, and so now we have, let's see here, we got 100. And once you learn how to master this, it becomes really easy to take one look at this waveform and tell what's going on with your patient. It really does. And you'd be alarmed at how few people actually use this on a regular basis. Yeah. Yeah, we got a bunch of average RTs out there, unfortunately.
Did you get that from that guy's video?
What's that?
The respiratory therapist that you always give us videos for? I watched his video. He's like,
Did you watch the video? So yeah. Oh no. I mean, like, I've always been, kind of a geek for this kind of stuff. But like sometimes it's, when you're looking at other stuff, when you're trying to like do a lesson plan, it's always good to look at some other stuff, and maybe get a couple things. But yeah, but it's true. Like I got a bunch of guys. Like like I said, I got friends that do PFTs that couldn't interpret a PFT if you paid them to. If you paid them like an extra $500, they couldn't do it. All right, it's just a little bit extra to be good at. And let me tell you something. One of the most gratitude I've ever had consistently is not people whose lives you saved, or like you cared for an event. It's the people that you explain stuff to and tell them why things are happening. Like when I interpret a PFT, like right after it's done, and they don't have to wait 3 to 4 weeks for a doctor to call them so they can figure out what the hell's going on, and they are so thankful. It's amazing. All right. So anyway, so what happens here? Where does everybody usually start off on PEEP? Like
at least 5.
5, right? That's where everybody starts off on PEEP, right? So if you have, especially ARDS patients, and you have, all right, well, so let's do this. Let's do this here. So a normal, excuse the shaky lines here. I don't really have great hands here as far as like, so this is not supposed to be like a bird's beak. It's just supposed to be round, right? So this is like what a normal pressure volume loop is going to look like, all right? So let me guys ask you another question here. So what do you call, what's the main thing we're seeing in this vent? I mean, there's several things, but what's the main thing we're seeing on this loop here?
Shows you the tidal volume, right, between the pressure and the.
Okay, but what is that called?
The I don't know.
What is that? What is that formula for?
It's not the compliance, is it?
That is compliance, right? This form, one of the most important things you will see from this loop or anything on that vent is compliance. Without having to look at the numbers we have, this is the change in volume with the change in pressure, right? So delta V divided by delta P. This is the formula, the simple formula for compliance, all right? This is average, all right? Just take away this little part here, because I don't have good hands here, but take away that. But this is normal, all right? So that's what we're looking for. Okay, nice. Now, this is what we will see with a ARDS patient usually, all right? And once again, excuse the asymmetry here. All right, so look at this part here. All right, see this line here? This line here, would you say that's high compliance or low compliance when your line looks like that?
I can't see which line you're talking about.
The green line.
The whole thing?
No, just this part right here. From
I can't see the mouse.
From here to here.
Oh yeah, that's when we're looking at the peak, right? You want to look at the.
So yeah, so you see what I'm saying? So look at the compliance right here. So this is very low compliance. Everybody understand that? That means very little volume change, although that the pressure is increasing, right? Very little volume change. All right? Everybody understand that? This is volume, right? From here to here, very little volume has changed, but the pressure has gone from 5 to, say, 13. Very little volume change, all right? This inflection right here, where it starts to go up at a higher slope, this point right here is what we would call optimal PEEP. This is really where we want our PEEP to be. We don't want to have to add all this pressure into the lung every single time because we have to reopen the lung every single breath. So we want it to be right here. This is where we start our actual efficient ventilation right here. This point right here. Everybody see that? So this
Are you talking about the second line by the 13, like that inflection, or are you talking about by the 5, like so that first?
No. Okay, so right here, right? This is where we start. This is where at peak. I'm sorry, it's not a perfect drawing here, but from right here to right here, we have very little lung compliance. All right, we have.
I can't see your mouse, so I don't know where right here
Yeah,
is.
it's lagging very bad, so we can't see your.
You can't see the mouse?
It's super laggy.
Oh, is it? Hang on. Is the other program any better?
Which one?
Is the other program any better as far as there's like 2 whiteboard, isn't there like 2 whiteboard programs? So you guys can't see my cursor?
No.
Oh, I'm sorry. Oh man, I'm sorry about that. Let's see here. Okay, let's see. Let's add note here. All right. No, let's do that. Oh no. How do I get rid of a note? Okay, there we go. All right. Can you see the cursor now? It's a little different. No?
No, I don't see anything.
Okay, let's try this here. There we go. All right. Can you see it? Can you see this here? Where I'm drawing?
Negative.
Nothing.
See the black mark? I'm drawing like a little black mark.
It's delayed. It's like you talk about it and then a little while later it'll pop up. Now I see it.
The black mark just popped up.
Okay. All right. So this is where the PEEP is now, right? So from here to here is low compliance. Can you guys see that?
Yes.
Yeah.
Okay, so that point is low compliance because there is very little change in volume, even though we have a pretty good change in pressure. Okay, we good?
Yes.
Okay, so let's do this now. So from here. Okay, now you guys see the second line?
Yes.
Okay, so this is good compliance, right? Everybody see that? Look at the shape of the line. Very little pressure change. Very little volume change with a good pressure change, low compliance. Now we have increased compliance. Increased compliance. All right, because look at the slope. We have a good amount of volume, with a decent amount of pressure. All right, this is where we max out at this is our tidal volume here, right? This is where we max out on our tidal volume. Okay. Okay. Everybody see this?
Which part?
Okay. Okay, so everybody see where it says COP? All right. That point where it goes up in inflection?
Yeah, we see that.
Okay, so that's your critical opening point, right? That is where your optimal PEEP is. That's where the alveoli are open, all right, and ready to receive efficient ventilation. All right, at that point, where you see the change in the slope. All right, now, if you look at, if I see where CCP, so this is the critical opening point. All right, everybody see where the CCP is? Up top, the arrow, CCP.
Yep.
Left, yeah.
That is the critical closing point. That should be the minimum PEEP you have. That should be the absolute minimum PEEP, because at that point, the alveoli start to close, so we start to lose volume. All right, we don't get any more volume. We just start to lose volume there, and that's when it starts to shut down. All right. So when we're looking for minimum PEEP, this is minimum PEEP. This is optimal PEEP. And if you use this to figure out where you should be, you know, pressure-wise, volume-wise, all right, this is the most efficient way to ventilate your patient, all right? So when I changed them over to spontaneous CPAP mode, all right, oh, Lord. So when I changed him over, I wound up getting higher volumes with a lot less pressure because I increased the PEEP, all right? And all of the pressure I was using to ventilate. It wasn't using to reopen the alveoli every breath.
Can you say that again? Because I know that when I looked at his loop, I did notice that it was like really tall and high. So I know that you had increased the compliance and it decreased resistance, but
so yeah, so this is right. Okay, so what part do you want me to repeat? So let's talk about, okay, this is our optimal PEEP. OP represents our optimal PEEP, right? Right where the inflection, where the poor compliance stops and the good compliance starts, that's the optimal PEEP. All right. We start to go up, we get all the way up to our tidal volume. Now we start to exhale. All right, we're exhaling, we're exhaling, we're exhaling, we're still at the same pressure. All of a sudden, the pressure drops off, right? Those alveoli start to close, all right? This here, where it's about to drop off, this should be the minimum PEEP. That should be the minimum PEEP that we set.
I get that part, but the part that you said about the patient, how you changed
So,
his and how.
So what happened is this. So now, if say this guy's on pressure control, right? All right, say he's on pressure. Say he's got 15 pressure control over 5 PEEP, right? Where's his tidal volume going to be? Based on this.
A little less than 300.
So right around here, right?
Yeah.
So if we're gonna add 15, right? Say we're on pressure control, right? Because this guy's, you know, he's in lung protective mode, right? So just say, so he's 15. So right around here. So this is where, right around here is where he's gonna max out on his volume.
Yep.
Jill, you see that?
Yes.
Do you understand it? All right. So now, if I move my PEEP to 12, right here, which is optimal PEEP, right? And I add 15, where am I getting my tidal volume?
At 28, which is
Right around 28, right?
Or higher than the tidal volume we have drawn.
It'd be higher, yeah.
I got it.
So, yeah. What do I need? What do I need to get? If I start at 12, what do I need to get to the tidal volume we need here? Or say, what's that about? Just call it about 25. So we're talking about 13.
13, yeah.
All right. So instead of 5 and 20, you know, this is a much better use of our pressure. You understand?
Yes, it's like which settings can we use to get the optimal
Yeah.
amount of
Yeah.
PEEP?
Yeah.
Lowers.
By adding, by adding the pressure where it's efficient, right? Now we know that having to reopen the lungs every single, the alveoli every single time is not an efficient way to ventilate our patient. All right. So let's take a look at something. Let me erase this now. How do you erase the whole thing? Okay. Why is that thing not going on? All right. All right. So let's do the same loop. So okay. Okay. So now we have just, we still have volume and we still have pressure here, right? All right. So when you see volume pressure loops or pressure volume, however you want to call this, all right? When you see one like this, what is this telling you? Is this patient compliant or not very compliant?
Are you talking about the bottom one or the top
Oh,
one?
I'm sorry. My bad. I keep forgetting you. That one there.
That one there.
That one's
So
less
we-
compliant.
Less compliant.
Less compliant, right? Because you're adding a lot of pressure and you're not getting much volume at all, right? So this is less compliant. All right. So now you have to do something about that. This one is increased compliance. Now let me ask you a question. Now, what type of patient usually has this one here, the most compliance?
Is it emphysema patients?
Yeah, like COPD patients, right? They're very floppy lungs, very compliant. All right. So once we see this, what do we know we have to do?
The bottom one?
No.
Also the good
So
compliance
I'm
one?
talking about. Let's think outside of when we see a patient like this, we're flipping through the loops. All right. We see a loop like this. Now we have to make sure we have a good I to E ratio, right? For this type of patient. Everybody understand? Because normally somebody with this compliant of a lung is either like an OD patient, maybe a young kid or something like that, or an emphysema patient. All right, so then we have to take a look at what kind of history we have. Let's fix the I to E ratio. So this graph could tell you, hey, it could also give you other ventilation strategies. You understand what I'm saying?
So the bottom one, the one that has
This would be like a normal ARDS type of patient. Very hard to get volume in, like increasing pressure. All right. So this would be ARDS. This would be more like an ARDS patient.
the I to E ratio would be something that we would look at that patient.
Well, for this one, we have to worry about increasing PEEP, right? And what do we do with ARDS patients? Usually high PEEP, low volume, low pressure, right? That's why. Because they're non-compliant and we have to efficiently give them volume, all right, without adding too much pressure by keeping pressures down. Like when I first started with that guy, I had like a 14 PEEP and he was only on a 4 pressure support. All right, only 4 pressure support. So my peak pressures were a lot lower than anybody that was volume controlling him or pressure controlling him. I just had increased PEEP, to 14. But a lot of people who are, maybe doing the business a long time, they're really afraid to use PEEP. But when you have an ARDS patient, you do what you have to do, and you figure out, what you have to do to your patient to, ventilate him correctly. Everybody see this? Okay. So, any questions on this? Okay.
So then, this patient, you said the bottom loop is like ARDS. But then the patient that we're talking about COVID, and you said like a lot of COVID patients present with ARDS. So then, why was his loop so vertical?
Because I started him off. He had a high PEEP.
He had a high PEEP.
Yeah, and comes to find out that he'd been smoking for a long time, never been diagnosed, but he probably had, probably had emphysema.
And then like,
wasn't his peep like at 8 or something?
So, I think when I took the pictures, I'm not sure when I took the pictures, but his peep was increased. Yeah. Because he was on, what was he on when I did it? Yeah, he was on 14 peep when I had him.
and then like, so for optimal compliance, like looking at the graph, like looking at the loops, like it on the one that you sent, it was so small, it was hard to tell where the picture was up. But you can also calculate that, right? Like you can also
do what? Say that again.
You can also calculate the optimal peep by looking at the.
I mean, what you can do is if you have certain vents, you can actually point to a point on the you can like go little by little on your peep and then check the compliance. Your static compliance. So put it up to say 6 peep, all right, for a little bit, about 30 seconds, and then check your static compliance. Put it up to 6. Check your static compliance. Put it up to 7. Put it up to 8. You could do it that way too.
Got it. Okay. Yeah, that's the way that I was familiar with. But then I like looked at the graph and I was like, I know there's supposed to be a curve somewhere, but I couldn't see it. So, okay.
And so
makes sense.
this guy had been, this guy was coming. He had kind of turned the corner. So, but originally when I first picked him up, I came in on Sunday. This is what his loop looked like. And you can also judge. Hang on a second. And and as you come through and you get your medication, and he was taking was it Rasmadet? What's it called? What's the
Remdesivir.
Remdesivir. Yeah. So he had been taking that for a little bit. So things have started to get a little better for him. All right. So let's same loop. Okay. Now. Okay, so when you're looking at this loop, there's a couple other things you can actually see on this. All right, so if you have, shoot, let's do this first. Okay, so if you have a loop that looks like this, relatively thin, right? Easy up, easy back, very little space in between inspiratory and expiratory. All right, and then, you have something like this. Where the distance, between the inspiratory and the expiratory widens out. All right. All right. What does that tell you about the patient?
I'm gonna guess that they're air trapping, but I have no idea.
Anybody?
The distance between the I inspiratory to the expiratory.
Mm-hmm. So easy in, tougher time out. What does that tell you?
Obstructed.
Obstruction, right? Obstruction, resistance. All right. So when you see a patient go from thin to thick, suction, whatever you would do, lavage, whatever you do to help with airway resistance. So when you see changes like that, okay, it's for whatever reason now this guy is starting to have a harder time exhaling. He's having no problem getting the air in, and his looping is bowing way out. It's taking a lot longer time to exhale. Okay. Let's take up a different loop here. Okay, this is everybody's favorite loop here. The old flow volume loop. Mhm. Okay, so this is a normal flow volume loop that you might see on a ventilator. Everybody familiar with that?
Yes.
Everybody? Is everybody still here? Was it just me and Jill hanging out today?
No, I'm
I'm
here.
here.
You guys good? Okay, so
Right
Take
here.
so this is a normal loop, right? So this is what we expect to see. We have now remember inspiratory side, all right, is the forced one. It is forced on the vent, right? This is what we push inspiration. We force that into them, right? And exhalation is more of the passive side. So this it's upside down compared to what we do in PFT. All right. Now let's see. Okay. Now what does that tell us?
Patient is obstructed as well.
Okay, so we're very much obstructed here, right? So what do? We make sure that we use a proper I to E, right? So this patient needs more time to exhale than a normal patient. All right. Everybody understand that? It's gonna look just like a PFT flow volume loop that has obstruction. It's gonna look that just upside down. All right. Okay. How about this?
Is there secretions and stuff?
Secretions, resistance. Yeah, we have resistance in there all of a sudden, right? But most likely that resistance, if it happened, between, vent checks, this is going to be secretion. This is going to be time to suction a patient. All right. And what other ways when a patient's on a vent, besides listening, could we tell that we need to suction a patient?
Grab the expiratory limb and hold it.
Grab the expiratory limb and hold it.
Yep.
Okay.
Yeah, they always say that to see if there's wiggling. That means there's secretions. But I'm assuming you're talking about different older flow of waveforms. You can see jaggedy.
Well, yeah, but it doesn't necessarily have to be on the vent. How other ways can we do it?
Can we just check the PIP?
Yeah, we can check the PIP. All right, but what if the PIP didn't change? What's another way to find out?
Just go fishing and see what you get, Shove that thing down there.
That makes the patient very happy, bro. Let me tell you something.
We're running out of options here.
I told you a story. The guy call me a name, a racially charged name, because he remembered me suctioning him while he was on the vent, man. Yeah.
Wow.
Yeah. But listen, hey, I wasn't mad at him. I would want to be fucking, excuse my language, sorry. I wouldn't want to be suctioned like every hour on the hour, This is like when I was new, So what did we learn yesterday? What are some of the things we learned yesterday?
End-tidal CO2.
End-tidal CO2, right? We got a normal, right? Plateau, and then drop. Excuse, not straight line. We got plateau, normal, and then drop. All right. What's it going to look like if we need the suction?
The plateau won't be a plateau.
No plateau, right? It's taking all the time during the breath just to get it all out. You never actually get to the plateau. All right. If you see something like this is telling you, hey, I need to suction this guy. This guy is all of a sudden, this guy is obstructed. All right. So that's another way you could tell, listening to the patient. Sometimes you can't really hear it. You can take a look at all your loops, take a look at your end tidal. So there's several things you can do in order to, see if a patient needs to be suctioned. Learn to be the master of your ventilator. Seriously, it's what separates us in the hospital. All right, that's the one thing that we have the expertise on for the most part. The vital part, and don't know just the basics of the vent. All right, spend some time with the vent. know what every loop means, how to do it, every mode, how to wield that mode, because it's going to be a day when you're going to get there and you're not going to be able to ventilate a patient for nothing. It's like you're going to go through every mode that you know how to do. You may text your friends like, what the hell do I do? And it'll be that fifth mode for whatever reason that will actually work on that patient. But know how to set it. Don't be that guy. Mhm. That the stuff that you learn here in school is good. It's good to pass the test, but you need to do more to be a good RT. Like especially, this kind of stuff. Like it is true, it's what separates the average RT from, the excellent RT, the RT that the nurses like to work with because they know, hey, if I call this guy, he's gonna know how to fix this. So breath stacking is a huge deal, and you can't work as an RT for a month and not see a bad case of breath stacking. You have to know what to do, and you have to know how to change vent settings, not just based on. Let me tell you something. I don't use ideal body weight. I don't use it anymore because it really doesn't. Yeah, we just don't use it. It's not something that we do. Something that you do just for school, and then, once you get out, you kind of look at somebody, and determine you're gonna start at 500 or whatever, and then you're gonna go from there. Then you're gonna look at loops, see how they're, then you're gonna look at your loops and your waveforms and see how they're doing, and then you'll alter it from there. You learn ideal body weight here in school, and then you really learn how to use a vent when you get out. Be the masters of anything any advice I give you, be the master of the ventilator. And most of us will not be.
That's very encouraging. But I have a question.
Sure.
So for the volume loop with on that patient of the week, I was looking at it, and I'm not the best at waveforms. It's something I'm still working on, so that's good. But I did notice that like on the exhale, it was going below baseline. I was thinking that's because it doesn't have enough time to exhale the tidal volume all the way. Is that what that going below the baseline? The loop?
But you know what vent mode he was on?
It was on. I thought it was like on.
He was on spontaneous, right? So he's providing all the rate. He was getting just pressure support. So there's nothing else I could do for him as far as far as giving him more time to exhale. I mean, he had a high, I gave him a high, like a very small eye time. So the pressure support, the flow he was getting from the pressure support was coming quick. All right, but he was providing all the rates, so there's not a whole lot you can do with that.
Okay. Yeah, I think I was like looking at the pieces and I could see little things that were wrong, but I was like, I don't. Putting it all together was a little bit of work, and then it's been a while since I've seen a nice PB like that, so I had to go back and remember what all these little things mean.
It's tough, where are you at right now, Jill?
I'm at St. Joseph's. We have like 5 different vents right there.
Okay. So when you have a chance, go through all of the vent loops and see what's going on with the patient. Seriously, it'll be on your lunch break. It'll be the best hour you spend.
We don't have any extra vents, man. We're like at 52.
No. I'm talking about on your patients. When you take a break, when your RT takes a break, and I know they do, just go, hey, listen, I'm going to go check out this person. I want to go see what the loops, and just go through all the loops and see what they show, and you'll see exactly what I'm talking about as far as like, okay, this person's compliance. We should probably be doing this a little bit better. Study the loops and watch them. And watch how they change. And they change from minute to minute, sometimes from hour to hour. And you would try to adjust the event accordingly. But really, next time, we read Sunday, Monday, Tuesday. Spend every time you go do a vent check. Put on the volume pressure loop and just watch it for a minute or so.
Okay, yeah, I can do that.
And you'll know you're giving too much pressure or whatever mode you're on when you see the the bird beak, right?
Mm-hmm.
You guys, I figured that's probably one of the things that they always show, the bird beak here.
Yeah, the over distension one.
Oh, over distension, yeah. So if you got something like, all right. So once again, you get to a point where the compliance goes down, where you're adding pressure and you're not getting any volume. All right. So for compliance, this is over distension right here. This is probably where it should be. And yeah, that bird beak is no bueno. You got to decrease the pressure or adjust it to stop doing that. That's an easy way to get some barotrauma there.
And then on patient of the week, I couldn't tell. I thought it looked like a little bit of a bird beak on the edge, but the way that the loop was, wasn't clear. Did that have a little bit of over distension or not?
So what was happening is, like I said, this guy was changing, and we were really in the middle of changing his settings again, because he wound up after we had started, he wound up having a pneumo. So he had some other issues going on. He had turned, as far as like his temperature was down, and like a lot of the symptoms were lessening. His compliance had gotten better, but he had a pneumo. He had a small pneumo, so we had to back off the pressure a little bit. And so if I remember correctly, it might have had just a little bit, but maybe just a tiny bit of overdistension. Yeah.
Okay. Yeah, I did my patient of the week, but I wasn't really sure.
Oh, listen, all I really wanted people to do is look at it and think about it and tell me what they think they see.
Well, this is really helpful. I answered a lot of questions.
Any questions, you guys? Learn your loops and your waveforms, man. Really, learn how to operate that vent the best way you can, and you'll never be at loss for a job.
Thanks for going through them today.
What's that?
Thank you for going through it today.
No problem, man. No problem. Listen, if there's anything you guys like, it doesn't have to be PFT. If you guys have questions on something, it can be anything. And if if you at least you give me like a day, if you tell me like on Thursday or Wednesday, hey, can you, talk about this, then I get enough time to make sure I know exactly what I'm talking about here. But you guys have really done. Actually, you guys have made me really, stretch this term. You guys are usually, like, most of the classes, they don't give a damn. They just kind of, they want to do the minimum and they do the thing, and but you guys have actually made me stretch, which is good. Make me a better RT, maybe a better teacher. So I appreciate that. Dude, you've already done the project, brother. What are you still? I didn't think you'd have any more questions, man. Go ahead, man. What's the question?
No, I'm having a hard time trying to find the information to do the assessment. Like, I went through like all the links that you provided.
What assessment are we talking about?
The this week's assessment quiz thing.
The
assignment. I'm sorry.
So which was the topic again, man? Well, we've done so many.
Capnography. It's in week 10, I think. It's in the week before this week. I had the same problem.
Capnography?
Is it?
Are we doing a capnography?
The homework is capnography.
In town. Yeah.
Yeah, it's the week before, man. Because what happens? Remember, we did the we pushed everything a week.
That's right.
Yeah, just go back a week.
Okay. Thank you.
Hey, man, a little less beer.
Hey, well, it wasn't the beer.
Okay, a little bit more, yeah.
I don't wake up and drink.
Yeah, okay. Anyway, any other questions, ladies and gentlemen?
Yes, sir.
Sim, you got any questions, brother? You understand the loops, man? You understand this loop alone? Will save patients, man, and will help you be a better RT by just learning that loop alone, the volume pressure loop.
Yeah, I just got to go through each one and kind of figure out what the main issue is, because loops on like ventilators are probably one of my weakest points next to hemodynamics.
You know what? What I'll do is did I already put Jill, did I already put the guy's video? Because this guy is really, I don't know why, but he's like so country simple. He makes it very simple for people to really watch his loops and watch his videos. The respiratory coach. I'll put it in the next one, so you can just take a look at that, man. I think it's like 15, 16 minutes. He does a really good job of going through it, and labeling it. I mean, you can watch a lot of different videos. Like I've watched 25 videos on EKGs. And everybody they kind of say the same things in a different way. Just kind of like you just kind of for whatever reason that guy he breaks it down a little more simple. But I'll put it in the content for matter of fact, I'll put it in the content for this week. All right, I'll take his link and put it in there.
And that Prost guy has one too, the PFT guy.
Oh yeah. He does too. Yeah, right.
His is pretty good too.
The only problem with his videos is like you got to get like a surround sound system and turn it up.
Which one? Which guy? The Prost?
Alan Prost guy.
Yeah.
His
now the good thing is
hard to hear.
Yeah. Listen, let me tell you something too. We have so many resources now. Like there's so many videos out there. Literally, you could probably never read a book like like any type of respiratory book and still learn all you need to know about respiratory therapy. Use your resources. Like I'm a video watcher. Like I have to be, like I love to watch videos. I watch videos like constantly, like to and from work. I'm watching the videos and listening to these guys and stuff like that. That's probably why I don't have a relationship, like goofy quirks like that. But use your resources. All right, these things are here for you. You have teachers, like Matt Angelo out in the field still. He's looking at these things all the time. Mr. Robles out in the field. Oh, and you guys pray for Mr. Robles here. He's positive COVID. So if you get a chance, when you spend your personal time with whoever is your higher power, make sure you pray for Mr. Robles. All right.
Will do. Yeah.
So yeah,
will do.
Use your resources, man. There's so much out there. There's so many. So there's never a reason to be an average RT. Really is. And one of my favorite things about working at the school, it's not the money, definitely, but I get to choose who I really want to work with. Like I get to handpick like the people that I really want to work with. So, which is nice. Not many people have that luxury. So, when I teach, I try to always include the stuff that I would want you to know if you would come into my clinic. So take this information and and use it and remember it. And when you get out into your clinics this week, look at the ventilator. Change. Don't just use whatever waveforms they have on the screen. They all have more. They all have different ones you can look at, and they all tell a different story. But this one tells a big story.
Well, thank you for your time. Thank you for sharing your knowledge with us. This was really helpful.
No problem, you guys. Listen, I appreciate you guys coming to optional meetings, man.
It was fun.
I appreciate it. All right, you got Marissa. Hang on a second. Marissa, no questions from you? Seriously?
I know.
Are you okay?
I'm a hot mess.
Are you okay?
I'm a mess today. I don't know.
Should we send you for COVID testing? You can't be right. Like I haven't had like one question from you.
I know. I'm a mess this week.
What's the matter? Everything all right? Can we do it? Well,
Yeah.
Can I do anything to help? Are you good or what do you need?
I'm good. Just nothing. Overwhelmed. Have lots of stuff to do, but
All right.
You gave
that's
me the
okay.
heart.
Yeah, you gave me the heart this week. That's what's doing
gave
it.
you the
I
heart.
hate the heart.
Okay. All right. Well,
Yeah.
fortunately, just a lot of that stuff is not what we do on a regular basis. Most hospitals you go to, you won't have to do EKGs. But anyway, you'll be fine. All right, you guys. Listen, if you guys don't need anything else, like I said, I appreciate you guys doing the optional stuff, and not just doing, the minimal, and let's get I'll have Heather send out the tutoring schedule for the week. Let's get that going. All right.
I'm gonna need to be in the tutoring every day.
You'll be fine. You'll be fine. But No problem. You can join anyone you want. All right.
Alrighty. Thank you.
All right, you guys. Have a good one. All right. Bye-bye.
Yep. Have a good one.
All right.
Take it easy.
Thank you.